I have some suggestions here for you, hoping they're not too simple. They come from a book that I recommend. It's called Counseling Skills for the Non-Professional Counselor. And the authors are Kennedy and Charles. The book's been around for a long time, and it's really good. And it's really good for clergy, because if you're in a situation where counseling is not your day job, but in fact you end up getting people in your office regularly with mental health issues, the first recommendation is you ought to try to listen to the person. Clergy, part of their job is to preach, and so sometimes it can be difficult to rein in the preaching. And so preaching is not really what you want to be doing when someone's coming to you with this difficult, painful issue. Listen, you know, we know from research that the medical doctors who are the most successful at diagnosis are the ones who are able to listen to their patients. We also know that patients are remarkably inept at adequately describing their symptoms. Patients say things like, I just don't feel so good. Patients say things like, I don't know. It just doesn't, I'm just not feeling very well. And so the really, really good medical doctor probes and asks and goes after the details so that they can listen to the patient. It's also important, I think, not to over-focus on the problems. It's a strength-based approach. People already know how much difficulty they're in. They already know that if they could have solved it themselves, they would have, and they wouldn't be sitting in your office. But what they might not know is how much strength and resilience they demonstrate. And so one of the things that you might want to ask people is, what have you experienced at other times in your life that were hard times, that were difficult, maybe even were catastrophic? What did you experience then, and how did you get through it? And suddenly you'll start to hear the enormous resilience that people have. And the last two guidelines are, don't try to do good and don't try to do well. And this has to do with, don't be over-focused on your own performance. The issue at hand is what the client's going through, not whether or not you will be very, very helpful to them. And let me just say something about the ever-present issue of countertransference. Countertransference is that experience that you have with a person that is really linked to your own history, that colors or contaminates or otherwise distorts what's happening with the congregant or the client. Sometimes the reactions you have are not countertransference. They are communications from the congregant or the client. So the difficult differentiation that you need to make is whether the reaction that you're having is coming out of your past, your history, your experience, or whether it's coming directly from the congregant to you, and you are responding to it. So, for example, you want to ask yourself the question, what is being done to you in the meeting? What is being done to you? For example, I feel helpless, angry, frightened, sexually aroused, depressed. You could feel any one of those things in your interaction with the congregant or the client. That may be all about you, or that may be the kind of issue that the client is presenting you with. For example, if you feel helpless, You may be with a person who is enormously dependent, who is eliciting from you a sense of helplessness. Or if you feel angry, you may be subject to the passive-aggressive maneuvers, however unconscious, on the part of the congregant or client. If you feel frightened, you may be in the presence of psychosis. That's not an uncommon response to psychosis. I feel frightened. So you want to take that feeling and use it diagnostically. Don't think to yourself, something's wrong with me. You might think to yourself, I'm on to something. I feel sexually aroused may be that you are, in fact, with a person whose personality is histrionic and seductive, and with a person who sexualizes all relationships, including this one. If you feel depressed, you may be with a depressed person and you've caught it because it's catching. Just as anxiety is catching. If it's in the room, you can get it just like the flu. Just by way of a final little bit of input, I thought I would say something about the difference between the kinds of mental health issues that come to us. You want to make the distinction between neurotic symptoms, psychotic symptoms, and personality disorders. So, if we look at Axis 1 and the DSM-4, we're talking about neurotic symptoms, and they present themselves in the form of depression. The most common presenting problem in clinical offices is depression. And that can be mild, moderate, or severe. It can be simple dysthymia. It can be something more. It can be a major depression which paralyzes a person and makes it unable or very difficult for them to function in their lives. The anxiety disorders are very common, and they include obsessive-compulsive traits and disorders. It includes PTSD. It includes panic attacks. What we need to know is that different therapeutic modalities are appropriate for different symptoms, and one size does not fit all. So, for example, if the presenting problem is a phobia, you are not well advised to do analytic treatment to go back to the early roots of the phobic behavior, because 7 years later you will be working on that, but it might not have accomplished so much. If, however, you choose cognitive behavioral therapy and you say, we will do a kind of desensitization procedure and we will go step by step by step, we will do some form of exposure therapy whereby your anxiety was up here and we'll bring it down to here and you will be able to cross that bridge, that's successful, and there's evidence to show in the research that that actually works. Rigid behavior, excessive dependency, pseudo-independence, compulsive behavior, all neurotic symptoms, all having multiple ways of presentation in your office. Psychotic disorders have to do with problems in thinking. So when you're dealing with psychosis, you're dealing with disordered thinking. And when you're with someone and you think, gosh, that's a funny connection. Gosh, I never would have put those two things together. When you have a kind of loose associations that leave you just slightly off balance, you at least ought to be thinking clinically about whether or not this person's thinking is grounded and rooted and organized. The obvious stuff or symptomatic presentation with psychosis that you won't miss are hallucinations, which are either visual or auditory, seeing things or hearing things that are not actually there. Delusions, which is faulty beliefs. I am Jesus Christ. Not true. And disorganized behavior or speech, flat affect that simply can lead to a kind of catatonic behavior. Those are some of the markers of psychotic behavior. Churches and other houses of worship are magnets for some mental illness. And so in the church, synagogue, and mosque and other houses of worship, you will get a certain percentage of psychotic behavior. And it's really hard to deal with. One psychotic person in the congregation or the group can pretty much blow it up. And the task of the clergy person is to manage it, and the way that you manage it is through referral. And there are even times when you must say, I'm sorry, but you can't be in the room. I'm sorry, but you can't be in the service. I'm sorry, but you can't be in the group, which feels counter to religious values and ideals. But what you are dealing with is the tension between individual need and communal need. That's the tension that you're always holding if you're the leader. And if you're the leader, you cannot let the needs of an individual subvert the good of the whole. And I think that the really important thing, which is a kind of difficulty for many of us, is not to assume that the little plot of ground that I stand on is the normative one. And it's the one that's actually healthy. And the one that you're coming from is really a little suspect. That's where supervision is pretty important, and it's why we do it here at PSI every week. Because supervision is a way to be in conversation with other professionals, where if you say, if you make your statement and the others can say back to you, well, wait, maybe not. I think we're just about at the end of our time. Thank you very much. It was really a pleasure to have you.